Hello, and welcome to Health Loss Simplified. I'm Elizabeth Lippincott. I'm the founding member of Strategic Health Law, and I'm here with my colleagues Sandy Durkin and Katerina Wieses.
Hi, everyone. I'm Katerina. Today, we're going to tackle the Inflation Reduction Act, which is a sweeping federal law aimed at improving the economy, addressing climate change, and reducing healthcare costs. Sandy and Elizabeth are going to walk us through some of the healthcare changes and impacts they are having on Medicare Advantage and Part D plans. My first question is for Sandy. What are some of the healthcare reforms in the IRA?
Thank you for asking, Katerina. Rising prescription drug costs have been a big concern for both parties for a long time, and most of the healthcare changes in the IRA were really aimed at bringing down those costs, both for patients and for the government in their Medicare spending. So some of those big changes in healthcare and prescription drug costs are that the cost of insulin is now capped at $35 per month for Medicare members who are picking up their insulin. Cost sharing for adult vaccines is eliminated altogether, and that's for adult vaccines. It's not everything. It's the ones that are most commonly recommended: RSV, shingles, Tdap, and hepatitis A and B. Another feature is that the IRA created brand new inflationary rebates. Under these new rebates, if drug prices go up faster than the rate of inflation, manufacturers have to give that extra revenue back to the government. And then the part of the IRA that's gotten the most attention, you probably saw this in the press over the last couple of years, is the drug price negotiation program. This is really novel because it gave the government the power to negotiate prices with drug manufacturers for the first time. It's not a huge power grab. That power to negotiate drugs is really limited to a very specific number of high cost drugs that are covered by Medicare Part B and D. Right now, the initial phase of the program only involves 10 Part D covered drugs. So shifting gears, one aspect of the IRA that was overlooked in early reporting was what is called the Part D redesign. It didn't get as much attention because most of the big pieces of that redesign didn't take effect right away. But this is the aspect of the IRA that's having the biggest impact on Part D plans right now and in the next few years.
Interesting. Could you tell us a little bit more about the changes made to the Medicare Part D program?
Absolutely. So there's two buckets of changes. First, there are new beneficiary protections, and then there are changes to the way that those benefits are paid for. So in terms of beneficiary protections, there is a new hard cap on out-of-pocket costs for seniors at $2,000 a year. This is really significant because before, out-of-pocket costs were capped at $7,400 in 2023, and members, even after that cap, stayed responsible for 5% of their costs indefinitely when their Part D benefit went into the catastrophic phase. Some other new beneficiary protections are expanded eligibility for the low income subsidy, meaning that more people now qualify for the extra help that the government offers to pay for the Medicare drug coverage. And then another really novel feature of the Part D redesign is a new benefit that allows members to spread their drug costs out over the year. It's called the Medicare Prescription Payment Plan, or the M3P. And that lets people spread those, up to $2,000 in drug costs out, so that instead of incurring all of it at once, if it's a very expensive medication, they can make payments of a couple $100s a month. So that's a really great benefit. Very tricky for plans to administer, but really, really good for folks who need it.
Yeah, so that $2,000 annual cap was a huge change because even though there was, like an upper threshold to get into that catastrophic phase around 7,000 and change, that 5% cost sharing past that point could be really substantial if you're taking some of the new therapies that can cost hundreds of thousands of dollars a year or even more.
Yes, thank you. It's a really significant reduction of costs for members. So that raises the question, who's going to pick up those costs, especially for members that have really expensive medications. And that's the other big change that the IRA worked on the Part D program. It shifted the way that the government, Part D plans, and drug manufacturers share in the liability for costs over that out of pocket cap. So before the IRA went into effect, the government covered 80% of costs above the spending cap, while Part D plans were responsible for 15%. And then that extra 5% is what members were on the hook for above that threshold. After the IRA and all of the changes to the Part D program went into effect, Medicare responsibility, government responsibility dropped from 80% to 20%. And Part D plan liability went up from 15% to 60%. So that's a really dramatic shifting of responsibility. And then under the new changes, manufacturers do kick in 20% for brand drugs. All of these numbers are for brand drugs. They're a little bit different for generics, but the general idea that Part D plan sponsors are responsible for the bulk of costs once members reach that out of pocket cap remains the same. So, bottom line, lower costs for members, lower costs for the government, higher costs for Part D plans.
Thank you, Sandy. And for Elizabeth, what impacts are all of those changes having for Part D plans specifically?
Well, it stands to reason, if you have this really significant expansion of benefits, the cost has to go somewhere because Part D plans, a standalone Part D benefit is not going to have huge profit margins typically for plans. It's something, some organizations choose to do for strategic reasons as part of their overall product portfolio. But being a Part D issuer specifically, standalone Part D is not in general a huge moneymaker. So they're not going to take just a massive loss on these plans. So the money to fund all of these benefit enhancements has to come from somewhere. As Sandy explained, the statute decreased the percentage of the benefit that's funded by the federal government. And so premiums had to go up. And there was a premium increase cap in the statute. It capped up a particular benchmark used to calculate premiums at 6%. And my suspicion is that a number of legislators that voted for this bill did not understand that that was just one defined in the statute benchmark and not the actual premium that the individual buying the plan would pay. Because significantly, Part D, in contrast to Medicare Advantage, Part D is statutorily designed for there to be a member premium. So it's just a question of what amount that is going to be. So they had that statutory cap on a benchmark at 6%. However, once the bids came in for contract year 2025, which would have been last June, CMS saw how high the premiums were in fact going to rise, especially for enhanced benefits, which are very popular in Part D. And so what it did was create a demonstration program, basically to subsidize those standalone Part D premiums through, according to the memo they put out, 2027. So by memo, and it's probably quaint at this point to be talking about separation of powers concerns, but this wasn't even an executive order. It was just a memo saying, okay, so we're doing this, quote, demonstration. I'm sure it was all done with good intent, but there are potential legal issues with this. It's called, they put it out on July 29th, 2024, and it created what they termed a voluntary Part D premium stabilization demonstration to stabilize those Part D standalone premiums through 2027. Now, this did not apply to MAPD Part D plans. So this did not subsidize the premiums on Part D benefits that are integrated in with a Medicare Advantage plan. However, those Medicare Advantage issuers have more flexibility because of the reimbursement they're getting on the Medicare side to essentially subsidize the Part D program and absorb some of those cost increases. However, this was relatively controversial. Some congressional representatives requested that the CBO, the Congressional Budget Office, revisit its calculations for the impact of the IRA's Part D redesign. And we're not, this isn't a political commentary, but the IRA was a significant legislative achievement of the Biden administration. So there's a political overlay here. So they asked CBO to revisit its calculations of the impact of redesign and to forecast the impact of this demonstration program that CMS created with its memorandum. The CBO issued a letter on October 2nd, 2024, with some pretty astonishing conclusions. One is it reported that the average plan bid for a standard Part D coverage plan, which means before you even add any enhancements, increased 179% in 2025 compared to 2024. So, in my view, it was a little bit of magical thinking of anyone to think that all of these benefit enhancements could be done and you could somehow cap the premium increase at 6%. Well, there's no magic. It actually drove bids up 179%. The CBO also revisited just the overall impact of the IRA's Part D redesign on federal spending. And keep in mind, this is even with a lowering of the federal percentage of drug costs that it would be covering. And the CBO estimated that the resulting growth in federal spending would be $10 to $20 billion in 2025. And that's before you add in the demonstration program. And for the CMS demonstration program created by that July memo, the CBO estimated that federal spending would increase just in 2025 by roughly $5 billion. So if you were critiquing that on a separation of powers grounds, you would say, only Congress can appropriate dollars. A federal agency cannot choose to increase government spending by $5 billion, through a memo. So those are the legal issues involved. To put the spending increases in perspective, and again, this is not to harp on anyone politically, but just to see that sort of the size of the impact of this maybe error, I don't know, miscalculation, whatever, however you want to characterize it. If the CBO is saying that these Part D redesign changes will increase the federal government's outlays by $15 to $25 billion, that's when you add their recalculation of the impact of the redesign and then their forecast of the cost of that demonstration program. So, okay, 15 to 25 billion for those things. The government's spending that much more. You can contrast that with the projection of the Biden administration that their renegotiation or negotiation for the first time by the federal government of the high cost drugs that was the much more publicized change in Part D, that is forecast to save the government $6 billion. So $6 billion in savings on the drug negotiations compared with $15 to $25 billion of additional federal government outlay from the Part D redesign overall. So it's not a great story. And it's something of a political hot potato for the current administration because no one wants to see benefits cut after they've already been implemented. But there's a big question of, who and how are we going to pay for this going forward?
So, Elizabeth, how do you think this is going to impact the whole market overall going forward?
Big picture, it's hard to say whether the current administration will allow that demonstration program to run through 2027, as it was described in that memo. That really just kicks the can down the road a couple years. I don't have a prediction on whether they'll do that, but whenever these premium increases hit and really hit the market, it's going to make affording a Part D standalone plan to pair with a Medicare supplement plan, for example, much more expensive. And so it's likely to increase the attractiveness, relatively speaking, of Medicare Advantage plan with Part D benefits to offset some of that cost. So we see this as a real boost to Medicare Advantage that was really inadvertent on Congress's part, because that's certainly not what they were trying to do when they enhanced the Part D benefit. But it may make affording a standalone Part D and a Med Sup plan, which is what you need to do if you don't have group coverage or VA or Medicaid, to afford to stay in original Medicare, because without the supplemental in Part D, you'd be woefully uninsured. It's going to make that option more expensive. And we expect will really accelerate the increase in Medicare Advantage enrollment over the next few years.
Those are really striking figures that you shared, Elizabeth. And I just want to note some of the numbers that I saw regarding standalone Part D plans was that the offerings dropped significantly from 2024 to 2025. I think I saw over 700 plans were available in 2024, and that dropped to under 500 for 2025. And that's even with that demonstration program available. So it is a big question, what's going to happen if that financial model doesn't survive?
Wow. Yeah. Yeah. So choice is already going down in the Part D market. And this is my personal opinion, but of course, we work with a lot of Medicare Advantage plans. We see the value of that program, but I personally think there's value in competition, not only within the Medicare Advantage market, but that it is competing with another viable alternative that not just the wealthiest people in the United States can afford. And, for reasons having to do with state law regulation of Med Sup underwriting, which does vary state to state, but in general, if you want to go the Med Sup route, in most states, you need to do it in the first year that you have Medicare. Because if you get Medicare Advantage, have it for years, and want to go back, it can become very expensive if you even are able to get a policy. So, long story short, I think this potentially threatens the viability of that other option. And it's kind of crazy that we're talking about staying in original Medicare as the alternative option, because it used to be like the baseline default, and MA was this limited program. But I think we're sort of hurtling to the opposite of that.
I agree. And, I heard you perhaps wisely refrain from opining on what the new administration is going to do with this demonstration program. And we may decide to cut this at some point, but looking at the way that Elon Musk is really scrutinizing federal agencies for expenditures that the party doesn't agree with. I think it's only a matter of time before he turns his sights to CMS, and this voluntary demonstration program may be an easy target, an easy cut.
We'll have to see, because it's also politically dicey. Medicare beneficiaries are a powerful voting bloc, and no one likes to see benefits cut, and no one likes to see insurance premiums spike. So it really remains to be seen. I don't know what they'll do, but I don't think it's just going to be an ideological question. I think it's going to have to be a political calculation as to how directly they address this fiscal challenge.
Like everything in healthcare in this country, it's not simple.
No, it's not simple. And even when it is simple, it's not easy politically. Yeah, it's pretty dicey.
Well, thanks for walking us through your thoughts on how this is going to go down. I know the Inflation Reduction Act, it was passed in 2022, but we're really just starting to see the fruits come to bear this year and in future years. And, we will be watching to see how things develop, to see if there are legal challenges in the courts or if any efforts by the new Congress to address some of these issues, and we'll keep you updated.
If you enjoyed this episode, please subscribe wherever you get your podcasts. And if you want to find out more, go to strategichealthlaw.com. This podcast is for informational purposes only and should not be considered legal advice. If you need legal advice on any topic we've covered, please consult an attorney with appropriate experience in health law. Our music is Galaxy Love by Johnny Duke.